To begin with, we're going to review the ABP content outline, and you can see we're in the category 3 of cardiovascular examinations, principles, and application of cardiac diagnostics. Now, this category overall accounts for 9% of the certification examination, but echo Doppler comes in as a subset of this. And here's a list of the things that they want us to know for this test. So assess systolic and diastolic function. Yes, they do say diastolic function utilizing echocardiography. Know how to determine gradients and pressure measurements from Doppler-derived velocity measurements. Know how Doppler-derived velocity measurements compare to direct pressure gradient determinations. Understand the principles of echocardiography. That's fairly broad, but we'll do our best. Number 5, understand the physics of echocardiography, and that's not something that people often pass through more than once in their training, but I'm going to give a brief review of that. Know the indications for, risks of, and limitations of transesophageal stress and fetal echocardiography. And 7, recognize normal cardiac anatomy on echocardiography. So what I've done is I've taken these, the content outline and organized it in a little bit of a different fashion for our talk today. We'll go through ultrasound physics, hemodynamic measurements, and then we'll talk about ventricular systolic and diastolic function, then special techniques, which includes TEE, contrast and stress, and then I'll conclude with some examples, essentially working like flashcards with echo examples of various phenomena and diseases. All right, with that as our plan, let's begin with ultrasound physics. Like I said, we're covering this because it is specifically mentioned, and I'll try to do it in about 15 or 20 minutes. So let's begin with talking about sound. Sound travels as a mechanical longitudinal wave of compression and rarefication. Rarefication means things become less dense. And you can see a diagram of that. Essentially, you can think of it as a vibration going through the air. So here's the sound wave coming out of a speaker, less dense, more dense, less dense. And because this density varies over distance, you can represent it as a wave. And like other waves, it's got a wavelength and a frequency. And the frequency is how fast it goes up and down. And then there's the wave equation that many of you have seen before. It says that the speed is equal to the product of frequency times the wavelength. The important thing here just to mention is that the speed of sound is relatively constant in soft tissue, so when you're doing ultrasound of the body, and that it's fast. Specifically, it's 1,540 meters per second. That's nearly 5 times of the speed of sound in air. And the good thing about sound moving so fast as it goes through tissue is it means we can take pictures very quickly and form pictures very quickly. And so it's very convenient in that way. So what's ultrasound then? We've been talking about sound, but ultrasound means frequencies that are higher than those audible to the human ear. So that's greater than 20,000 hertz. But the frequencies that are used in medical ultrasound are in the range of 2 to 12 megahertz. And here a megahertz is 1 million hertz. So these are very high frequency sound waves. All right, now over the next few slides, we're going to be talking about how ultrasound waves interact with tissues. And we've simplified this down. There are 4 things that can happen when sound interacts with tissues. And we'll go through each of them one by one, and they're reflected in this diagram over here. The first is reflection, and this reflection occurs at the interface between 2 tissue types, for example, blood, and then moving on to myocardium. So here you can see the sound wave coming off the transducer, going through one type of tissue, and then moving into a different type of tissue. And reflection here is it bouncing back. The greater the difference in density of the 2 different structures, the more of this gets reflected as opposed to some of these other phenomena that we'll go through in a minute. These sound waves are reflected back, and some of them are received by the transducer to use, and that's what's used to form the picture. And now you can see in this example, the sound wave is perpendicular to the surface here, but if the surface is parallel, there's essentially very little facing the sound waves, and so there's really no surface to kind of reflect it back, and that's how you can get dropout. So this phenomena is illustrated here. If you look at the atrial septum, you can see that's oriented parallel to the direction of the ultrasound probe, which would be down here at the apex of the sector. And so there's no real face to reflect back things, so the sound waves can become dark and attenuated, and you can get this false dropout. In this subcostal view, however, you can see the atrial septum is oriented more perpendicular to the sound waves, and therefore it presents a face in order for those sound waves to be reflected back. All right, the second thing that can happen when sound waves interact with tissues is called refraction. Okay, this also occurs at the interface between two tissue types, again, tissue 1 and tissue 2 here. And what this means is that the sound waves are essentially bent or diverted, but they're still heading away from the transducer. And how much gets reflected back versus bent or refracted here depends on the different tissue properties of this tissue 1 and this tissue 2. Specifically, something called the acoustic impedance and what the angle at which it strikes the interface at. The third thing that can happen when ultrasound interacts with tissues is called scattering. Now, scattering is kind of a special phenomena. This happens when the sound waves interact with a rough or a small surface. So these are small particles. In this case, it's a little counterintuitive. Rather than the sound waves kind of rebounding in a predictable, kind of intuitive way, what happens is the sound waves are scattered in all the different directions. So every different direction. Now, some of these sound waves will make their way back toward the transducer, and that part of the scattering is called backscatter, and that will also be received by the transducer. So you have the reflection coming back, as well as that portion of the scattering going back, the backscatter. And then finally, the fourth thing that can happen is as ultrasound travels through a tissue, it loses energy, and it loses energy in the form of heat. And what this does is this means that the power of this ultrasound beam will weaken or attenuate over time and over distance here. And it turns out that higher frequencies have greater energy loss and therefore less penetration. So you can see that in this example here. We have different frequency transducers. So we have a high frequency, kind of mid-range frequency, and a low frequency transducer. And what happens is at high frequencies, the sound waves attenuate more and you get less tissue penetration, whereas when you use the 3 megahertz, the low frequency transducer, there's less attenuation, and so you get better penetration of the tissues, and you can see in the far field better. So less absorption with the 3 megahertz or the low frequency transducer gives you that better penetration. All right. So having done those 4 different types of interactions, let's move on and talk a little bit about image creation in ultrasound. It begins with the machine, the ultrasound machine, sending an electrical pulse to that transducer. And in that transducer, at the tip of it, there's something called a piezoelectric crystal. Now, essentially, you can forget that word probably and just think of these as magic crystals, because that's really what they are, okay? So we've got these magic crystals, and they have the following property. If you send electricity through them, they vibrate. And as part of that vibration, if it's up against a tissue, it'll do some compression and decompression. And now this sounds like what I began with. That's going to set up that vibration and set up an acoustic wave and send that into the tissue. Now, once it gets into the tissue, it goes through those 4 different processes that I mentioned earlier: the absorption, the scattering, the reflection, and the refraction. And the reflected and backscattered waves go back toward the transducer. And then the magic crystals just function in reverse. They take that sound wave, that mechanical energy, and transform it back to an electrical signal, and that electrical signal gets interpreted by the machine, and that's what helps draw the picture. All right, so let's just talk a little bit more about that. Here you have in this diagram a transducer sending out its sound waves, and the amplitude of that reflected signal will be shown as brightness. So stronger signal coming back, it's brighter. And then we also have to kind of map things in space. And the way this is going to occur is we're going to look at the time for the signal to come back, and that's going to give us some information about depth. So if you think about it, if it sends out a sound wave pulse and then stops and just listens, that signal that gets reflected back sooner is coming from the closer tissue to the transducer, the near field, and the sound waves that are coming back later are coming from the far field or further away. In a lot of ways, it's analogous to a thunder and lightning storm. You see the lightning, and if you hear the thunder right away, that means the storm is near. And if you have to wait 1, 2, 3, 4, 5 seconds, that means to hear the sound, that means it's further away. So that's what's happening here. If the sound wave comes back quickly, it knows to map it in the near field, and if it comes back after a longer time, it maps it further away. All right, and now with ultrasound, you have different types of image displays, and we're going to just briefly go through those. There's M mode, and here the M stands for motion. And what this is going to do is show you the image along a single line here. It's a line going from near to far. And as you can see in this plot of an M mode, it's showing you depth, so how far away you are from the transducer, over time. But you're not seeing anything left to right. You just get this one line here. And the brightness here is going to be determined by the strength of the signal, and that's in turn going to be determined by how much the sound waves get reflected back. So here you can see RV free wall here, the septum, and then here's the posterior wall, and here you can see mitral valve leaflets opening and then closing and then opening again. So that's M mode. And then there's 2D imaging. And this is sometimes called B mode, and here the B stands for brightness. And here now you have a diagram of what's going on in order to make a 2D image. So what it does is it draws the image sector by sector or line by line, starting at one edge and moving across to the other. So it draws this line really quickly, almost like a single M mode line, and then it does this one, and it does it sequentially. But because it's able to work so fast, again, going back to that fast speed of sound and tissue, you don't really notice or appreciate that it's drawing it one line at a time. So now you can see how things are across the entire sector, and it will update that quickly, and then you'll appreciate how things move over time. But we have multiple scan lines with the 2D imaging. And then finally, with 3D imaging, very briefly, what you have is instead of having, for 2D, you have the crystals arranged kind of linearly. Here, we have them arranged kind of in a square pattern here. And as a result, you can interrogate, instead of just a sector of tissue, a whole volume or pyramid of tissue, because you have these crystals arrayed in 2 dimensions. So let's talk about a couple of principles with ultrasound physics and imaging. We're going to talk first about spatial resolution and then about temporal resolution. So spatial resolution refers to the ability to distinguish between 2 objects in close proximity. So can you see them as 2 distinct objects, or do they look like kind of one single object, just bigger and blurred together? When you talk about spatial resolution, you have to think about the different directions. So there's the axial direction here, which is in line with the direction of the ultrasound propagation. There's the lateral direction, kind of the left-right direction on the sector. And then finally, there's elevational, which is above and below the sector plane. So we're going to just look at each of these individual briefly. So here's axial resolution, and your axial resolution, again, is how well you can distinguish objects that are along the line of the ultrasound beam. And it turns out your axial resolution is better with a higher frequency transducer, and it's also constant with distance. So let me just illustrate this with this diagram here. So this represents reality here. We have 4 different objects. These 2 here are close together. With the low-frequency transducer, we can't really resolve these as 2 separate objects. They're kind of blurred together. But here with the higher frequency transducer, it has that better axial resolution, and you can see them as 2 distinct objects. All right, now for lateral resolution, this is better with a narrower ultrasound beam. So the ultrasound beam can have a width. Here it's wide. It becomes narrower and wider again. And it turns out lateral resolution is better with that narrower beam, better with a larger probe size, and again, better with higher frequency, just like axial resolution, and it's also better with focusing. So what happens for lateral resolution is the transducer has the ability to narrow the beam down at a particular distance. And so what you can see here is that when the beam is wide, it's unable to distinguish these 2 objects as separate objects side by side. But as the beam narrows at the focal point, now it can see these 2 objects as separate objects here, and then it becomes wider. So lateral resolution will vary with distance, being best at the focal zone here and getting worse, if you will, proximal and distal to the focal zone. And then finally, elevational resolution. It's also better with a narrow ultrasound beam width. The focusing here is more limited. It tends to be worse with distance. So to kind of sum all this up, another point here is for resolution. When we're talking about spatial resolution, the axial resolution is better than the lateral resolution, and that's better than the elevational resolution. All right, now let's just briefly turn to temporal resolution. And what I mean by that is we're now talking about 2D imaging or 3D imaging. It's how long it takes the machine to draw that single picture before it updates and does another point of time. So again, we're back to, let's use a 2D example here. Remember, to draw this picture, what it's got to do is it's got to sample each and draw each of these individual scan lines. So how can we increase the temporal resolution, or how can we make it faster to draw one picture? Well, if we decrease the scanning depth, let's say to half the distance here, so from here to here rather than to back here, then you don't have to wait as long for that far field sound wave to come back and map its distance. If you only have it going out this far, you'll be done drawing that line faster so you can move on to the next line. So that will increase your temporal resolution or frame rate. If you narrow the sector, so instead of going from this edge to this edge, you narrow it in and make it, let's say, only from here to here, there'll be fewer scan lines to draw, and that will also allow you to draw the picture faster and have better temporal resolution. Each of these lines has a certain width, these little pieces of the pie. If you make them bigger or wider wedges here, then you will need fewer of them to cover this edge to this edge, and so you'll have fewer scan lines, fewer lines to draw. That will also allow you to speed up your imaging and improve your temporal resolution. And then finally, these are more minor points. Some transducers have multiple focal points. If you only have a single one, that will speed things up. And now some machines are also able to draw more than one line at a time, and I think it's intuitive, that makes sense, that you'd be able to speed things up as well. And then again, stepping back from this, M mode is faster than 2D, and that kind of makes sense. With M mode, its big power is you're only doing one scan line at a time, so that makes sense that that would have the best temporal resolution. That's faster than 2D, and 2D is faster than 3D. All right, let's move on to a little bit of a different topic in ultrasound physics. We'll talk about the Doppler effect. So here's a transducer. Here's an object moving toward the transducer. And what the Doppler principle is it says if the acoustic source is moving relative to the observer, you can think of the transducer as the observer, here's the source, the frequency of the transmitted and observed waves are different. So here's the sound wave going out. It has a certain frequency, rate at which it's going up and down. This object is moving, and it's going to reflect these sound waves back, but they're going to come back at a higher frequency. And here the object's moving away, and the reflective sound waves will be at a lower frequency. And the classic analogy for this is standing on a train platform as a train approaches, and the train whistle goes off. And as the train's coming toward you, it sounds like a higher frequency, and then as it moves away from you and leaves the station, it sounds like a lower frequency. So that's essentially the Doppler effect. So we're going to use that in ultrasound to help us measure velocity. Specifically, we're going to know that the frequency shift is directly proportional to the velocity. Now, you don't need to memorize this equation, but I'm putting it up here just to make a couple of quick points. So here it's saying how to calculate the change in frequency, and I've just rearranged this equation to this one here to solve for velocity. So what this tells us is that the velocity we measure is going to depend on the change in the frequency. That's that Doppler principle. And the other thing it's going to depend on is the cosine of this angle. And this angle here is the angle between the direction of the wave propagation and tissue motion. So let me show you that a little better in a diagram here. Here's blood flow in a blood vessel, and here's the velocity component. If I'm perfectly aligned with the direction of that velocity, I'll measure its velocity accurately coming toward me. But if the transducer is angled in respect to the direction of the blood flow, you will underestimate its velocity going along there. You'll measure a lower value, and that value, or how much you underestimate it, will depend on the angle here. So you can only measure the velocity component that's parallel to the transducer beam. And so if this is its full velocity and you're off angle here, you'll underestimate its true velocity. Now it turns out, as long as this angle is less than 20 degrees, you'll only underestimate it by less than 6%. And that just has to do with the property of how the cosine of this angle varies. But once you get greater, more off axis or off angle than 20 degrees, your degree of underestimation becomes significant. All right, let's talk about the different types of Doppler now. So there's continuous wave Doppler. Here's an example of that over here. You're familiar with this, I think. This is continuous wave Doppler at the left ventricular outflow tract. And so this is just sending sound waves continuously out along that Doppler beam path. And what it does is it displays a range of velocities along this entire Doppler beam going there. As a result of that, there's no distance or range resolution. In other words, I can't tell what the velocity is at a particular point. All it's going to show me is the whole range of velocities that are along this, but I can't localize it. And so that's why sometimes it's continuous wave Doppler is said to have range ambiguity. You can't tell at what point this particular velocity or this particular velocity is. The good thing about continuous wave Doppler is that there's no practical velocity maximum, and so it's very useful to determine the maximum or the peak velocity along the Doppler beam. We can contrast that now to pulsed wave Doppler, or PW Doppler. Here's an example of that here. Now the recording of the Doppler signal is taken at a fixed time after transmission. And again, if you think about how we talked about how image formation happens, if we're taking it at a fixed time, that means we're looking at a fixed depth or a particular point. So it's going to display the range of velocities at a specific distance. So sometimes it's called range gated. Range in this case means distance. It's distance gated. Now one of the downsides is there's a limit to the maximum velocity that can be resolved here. It's a limit in terms of how high a velocity can be measured. And if you exceed that velocity, the velocity will be misrepresented, and that misrepresentation is called aliasing. And here's a diagram just showing that principle. Here's our velocity scale here. It goes from this to this, and if that velocity exceeds the scale range, it will be shown below the baseline and essentially going in the opposite direction. And that's what happens when you have aliasing. And sometimes that maximum velocity, some people will call it the Nyquist limit. And it turns out that lower frequency transducers have higher Nyquist limit. And also if you have a shallower sample depth, that also can give you a higher Nyquist limit as well. Finally, let me move on and talk about color flow Doppler and tissue Doppler. So color flow Doppler, it's pretty intuitive, pretty straightforward. You're displaying the spatial distributions of velocity across this image wherever the color box is, and you're superimposing that on the 2D image behind it. And the velocities that are being shown here aren't peak velocities for each location. Turns out they're just the mean velocities. And color Doppler, like pulse wave Doppler, can also alias. Here you can see flow is away from the transducer, so it should be all blue. But we go down here, we exceed the Nyquist limit, the velocity maximum here, and it gets mismapped as red, as though it's or yellow, as though it's coming toward us. And you can see that aliasing over here. So finally, let's just turn to color flow Doppler and compare it to tissue Doppler imaging as well. And I just need to give you a little background just to make this make some sense. Here you have an image, and I'll just highlight the fact that myocardium is bright. It has a high amplitude signal. Blood is dark. It has a low amplitude signal. And then another point to understand here is that both of these structures move. The myocardium will move up and down, and the blood moves in and out. But blood moves faster than myocardium. Now, the Doppler principle doesn't care whether you're blood or myocardium. It just cares if you're an object coming toward or away from the transducer. So you can do Doppler on blood, or you can do Doppler on tissue. Typical color flow Doppler is tuned to do Doppler on blood, but we can also tune it differently to do Doppler on tissue. So with color flow Doppler, the machine is set to filter out the high amplitude or the bright signal, and it also is tuned to filter out the low velocity myocardium as well. So that's why you don't see the myocardium light up and the blood does light up. So you're showing the dark, fast blood signal. Here with tissue Doppler imaging, you're kind of flipping everything around. You're filtering out the low amplitude or dark signal, and you're saying filter out the high velocity blood signal, and that will leave behind the bright, slow myocardial signal. And you can do tissue Doppler here with this color display, or you can do pulse wave Doppler and just put it down on the particular tissue here and display it like this. But again, with tissue Doppler and color Doppler, it's still Doppler, and you're only detecting that velocity component that's parallel to the beam. And so finally, let me just sum up a few points with this slide, just going across the different areas that I've mentioned. That higher frequency transducer has better spatial resolution. That's a good thing, but it has less depth penetration, as I showed you in that example, and it has a lower maximum velocity limit or Nyquist limit with pulse wave Doppler. And then finally, the last point in the ultrasound physics section is safety. We just need to touch on that, and we can do this very briefly. There are no known adverse effects from diagnostic ultrasound at clinical imaging frequencies, so it's a very safe technique. All right, let me stop here, and we'll now move on to hemodynamic measurements. You've had your dose of ultrasound physics. That should be more than enough for the purpose of review as well as exam preparation. So hemodynamic measurements, we're going to begin with the Bernoulli equation. And what this equation really does is it relates blood pressure and flow. And it's based on the conservation of energy principle. And really what we're doing is we're going back and forth between potential energy in the form of pressure to kinetic energy and flow. And we're saying, yes, you might go from one form of energy to the other and back again, but all that energy needs to be preserved. So with that background, I'm going to show you the complete Bernoulli equation, and the purpose of this equation is to help you calculate the pressure difference between 2 points in space or along the path of blood flow. And I'm showing you the full equation because in the steps it takes to get to the typical standard Bernoulli equation that you're comfortable with or used to, there's some important points that come up. So here's that equation again, and there's three components to this equation. One is the kinetic component over here. This next middle portion is the inertial component, and then finally there's a shear stress component as well. So this middle one, this inertial component, this can be ignored if you're looking at mean or peak pressure differences. This is very convenient because that's mostly what we do look at. We look at mean or peak pressure differences. This third term here, the shear stress component, this can be ignored as long as we're looking at blood flow through a discrete obstruction. So think discrete valve stenosis. An example of something that's not discrete would be a long tube or a long segment obstruction. In those cases, you couldn't ignore this. And so that leaves us with this portion of the equation as well. So rho is a constant here. 1/2 rho turns out to be nearly 4, so we can replace this part here with a 4. So we have 4, and then we have the velocity at one point and the velocity at the second point. Okay, and the key here in this portion of the equation is to realize you need to square the velocities first before you multiply it by 4. And you can expand the equation if you want out, but that point still holds. Square the velocity first and then multiply by 4. Okay, and then the final simplification is if the velocity at the proximal point is relatively small compared to this distal point, then you can ignore this component of that equation, and it all simplifies to this, that the change in the pressure is equal to 4 times the velocity squared, and this is called the simplified Bernoulli equation. So, working now from those principles, here's the Bernoulli equation, but when does it not apply? It's not going to be valid if that V1 is not small. Again, we crossed it out with that assumption, But if that other velocity is not small, then we can't apply the simplified Bernoulli equation. An example of this would be stenoses in series. Think of subaortic stenosis and aortic valve stenosis. You need to be careful because you can't neglect that proximal velocity. Another example would be if you're not measuring that mean or peak pressure. In that case, that middle term couldn't be ignored. Well, that doesn't usually apply because we're usually measuring mean or peak pressures. But the third one is important too. So those viscous energy losses, that third term, is not going to be negligible in the setting of long or narrow vessels or a Blalock-Taussig shunt, for example. Here you can see this is not a discrete narrowing. We can't ignore that other term. And the effect of this is if you try to measure the pressure difference over a long tube, you'll underestimate the pressure difference. So you can go ahead and measure the peak gradient across a Blalock-Taussig shunt, but that's going to be the minimum pressure difference, and it likely underestimates it. You're putting a floor on that, but you're probably not measuring the pressure difference accurately. All right, let's move on and talk a little bit about flow going through a stenotic orifice, because that will allow us to get to a point that allows us to say why echo Doppler and cath measurements differ. So I need to give you this little background slide here. We're going to talk about how flow goes through a narrow orifice. Here you can see the flow coming in. This is the narrow orifice, and this is downstream from it. And you can divide this flow convergence into 3 different regions. First, up here is the flow convergence zone. We have non-turbulent flow that's symmetric. It's converging in and going through the orifice. The next zone here is the vena contracta. This is the smallest cross-sectional area. You can see here's the anatomic orifice here, but the vena contracta width becomes even smaller than the anatomic area over here, or the anatomic width here, as things contract down. We still have laminar flow here, but it's at this location that you have the peak velocity and also the minimum pressure. And remember, we're talking about conservation of energy here, so you're trading in some of that pressure energy for velocity energy. And so as the velocity goes up, that pressure is going to go down. So minimum pressure here. And then the third zone here is what's called the parajet area. Here we have viscous forces, and they create this eddies and these turbulences here, and you get energy loss, typically in the form of heat. So now let's look at that same concept in a little bit more detail with a slightly different diagram. Here we have a stenotic valve. This is a left ventricle, blood flow going through the valve and going into the aorta. And in this diagram here, we have pressure, and here we have the different locations as we make our way out across the LV into the aorta. And again, the principle here is we're going to be going back and forth between pressure or potential energy and velocity and kinetic energy. So we start out here, and we start moving down into the vena contracta. So the velocity speeds up, but as the velocity speeds up, some of that potential energy is converted in kinetic energy, and the pressure will fall. So here we are, the pressure goes down here, and at this point, the vena contracta, we have the highest velocity, but the lowest pressure. Okay, then as the flow stream widens, the velocity will slow down a little bit, and because, again, we're giving up some kinetic energy and recovering some of that potential energy or that pressure, and the pressure will come back up. This rise in the pressure here after the vena contracta as the blood slows down is called pressure recovery. Now, as we recover the pressure, we don't make it all the way back up to where we started for, because in the process of that turbulent flow, as you move into that, as things slow down and you have that viscous energy loss, you lose the energy in the form of the heat, so you don't make it all the way back up. So there's a couple of important things here. So this is the amount of pressure recovery. We don't make it all the way back up, but if you're measuring the pressure difference by echocardiography, typically you're measuring that peak velocity at the vena contracta. That pressure difference from here to here, this will be the greatest pressure gradient. But if you have a catheter tip and it's not located in the vena contracta, and typically it isn't, it's located downstream here, you're already after that pressure recovery phenomena has occurred. And so you'll measure less of a gradient from here to here, whereas the Doppler method will measure this bigger pressure gradient over here. So the Doppler doesn't take into account the pressure recovery phenomena downstream. All right, so with that allows us to go into the differences in echo and cath pressure gradients. We're going to do it over the course of 2 slides here, and I'll show you how each of those differences impact on the comparison. So first is, and again, remember, this is something they ask us to specifically address. So one reason you can have differences is you can have a velocity measurement error from an off-angle Doppler sample. That goes back to the slides I showed you earlier where we're not perfectly aligned with the direction of the maximum velocity. In that case, you'll underestimate the peak velocity, and therefore you can expect the echo measurement to be less than the cath measurement. Number 2 is in the cath lab, you're typically measuring the peak-to-peak gradient, whereas in the echo lab, when you do Doppler, you're typically measuring the peak instantaneous gradient. So let me go through that in a little bit more detail with this diagram here. This is a patient with aortic stenosis. Here we have an LV pressure trace, and then the pressure trace in the aorta. And you can see the pressure's higher in the LV and then lower downstream distal to the obstruction in the aorta. In the cath lab, you'll typically measure the peak-to-peak gradient, and so it will be this much. But when you're doing it by echocardiography, you're going to be looking at that maximum instantaneous gradient because you're not looking at peaks, you're just looking at points over time, and so you'll expect to measure this bigger gradient here. So in this case, the echo gradient should be expected to be bigger than the cath gradient. Third situation is that, as I mentioned just a moment ago, the pressure recovery is not measured by echo, and thus you can expect the echo gradients to be larger than cath as a result of this phenomena. A fourth situation is that the assumptions of the simplified Bernoulli equation don't apply. So, for example, if the proximal velocity is not negligible, but you assume that it would be, then you're going to overestimate the echo gradient, and because you didn't subtract that second velocity component from it. So you just used V2, and you didn't take away V1, and so that means the velocity you're working with is bigger, and when you multiply it by 4, you're going to get an artifactually big number, and that's going to lead to a higher echo gradient than cath. Another situation is that those viscous effects are not small. That's that Blalock-Taussig shunt example. In that case, you're going to underestimate the pressure gradient, so echo measurements are going to be less than cath. And then we can come up with some more situational things. Typically, echoes aren't performed simultaneously with the cath measurement, so the hemodynamics and the patient state might be different, awake versus sedated, so you shouldn't expect them necessarily to agree. And then finally, you could have catheter pressure measurement error. So we think of catheter measurements as gold standard, but in fact, you can have issues around calibration or damp transmission, air bubbles in the line, and that should also be on the list of things that can contribute to differences. All right, let's move on and talk about one more thing here in hemodynamic measurements, the continuity equation. And I need to give you a little bit of background before we can do that properly. So with Doppler, we're able to calculate the amount of flow across a region per beat. And the way this is done is by measuring the cross-sectional area at a location and looking at the velocity time integral. And what the velocity time integral is basically you do your Doppler over a location and you can trace it out and you're going to integrate the velocity over time. So we have time in this dimension, velocity in this dimension, and essentially we're going to calculate the area circumscribed by this velocity curve here. And if we take that number and multiply it by cross-sectional area, that's going to give us a flow number. And intuitively, you can kind of think of it as, okay, you have a cross-section here, and the velocity time integral is essentially saying, well, what happens if I take that cross-section and move it over time and space? That will circumscribe a certain volume, and that's why that works and allows you to calculate the flow per beat. So cross-sectional area times the velocity time integral, and if you know flow per beat and you know heart rate, you can then go to a flow rate just by multiplying the two. So how are we going to measure the cross-sectional area? Well, typically it's done by measuring a diameter and then assuming that this is a circle. Not always true, but that's typically the assumption that's made, and you apply the formula for the area of a circle. And then we also, in these calculations, are assuming that that area is constant over the cardiac cycle, but in reality it's probably not. And then the VTI, the velocity time integral, is measured either by pulse wave or continuous wave Doppler. And when we do these calculations, we're assuming that the velocity profile across the vessel is flat. So what does that mean? Well, we might put our Doppler sample from an apical view over here and measure the velocity here. But what this approach does is it assumes the velocity here is the same kind of edge to edge, when in reality it's probably not. All right, so with that background, that allows us to go to the continuity equation. And this equation is based on the principle of conservation of mass. Basically, we're going to say that the flow at these two locations has to be equal in the absence of intervening shunts. So at point 1, we have cross-sectional area times the VTI. Again, that's flow. So flow at point 1 has to equal flow at point 2 because there's no place else for it to go. There's no shunt. And that's the conservation of mass idea. So the utility of this is we can use this formula here to calculate the area of a stenotic valve. And you could say, well, why do you care about the area? Why can't you just measure the gradient across it? And the downside of gradients for looking at valve stenosis is that the gradient will depend not just on the orifice size, but also how much flow is going across the valve. And so the more flow across a specific defined area, the greater the gradient will be. So sometimes it's useful to calculate areas so you don't have it any confounding by the fact that the patient is in a low output or high output state. All right, so how does this work? So with that background, it allows us to come to the continuity equation as we would apply it in the echo lab. We'll use the example of aortic stenosis since that's the most commonly applied one. Here's a diagram. We're basically saying that flow in the left ventricular outflow tract has to equal flow at the aortic valve. So flow here has to equal flow across the valve. So how do we do this in practice? Well, we need the cross-sectional area of the left ventricular outflow tract. That's typically done by getting a parasternal long-axis view and measuring the diameter. Then we need the velocity time integral in the left ventricular outflow tract. That's typically done using a pulse Doppler signal in the left ventricular outflow tract. Here in this diagram, they've flipped the sector on us, but that won't throw us off too much. We just put that out and we measure the flow profile here. There's the velocity time integral. So we've got this and this. Cross-sectional area of the valve, that's what we're trying to calculate, so we can't get that. But then we need the velocity time integral of the valve. And the way that's done is by doing continuous wave Doppler now across the valve. That gives us another velocity versus time curve. We can calculate the VTI by having the machine integrate that, and so we can solve for this. Okay, so we have 1, 2, 3. That allows us to solve for the cross-sectional area of the valve and calculate a valve area. Now, it's important to realize that the valve area that we calculate is that effective orifice area, and that's not the anatomic orifice area because the peak velocity is in the vena contracta, and that goes back to that flow convergence principle we talked about before, how the vena contracta area is smaller than the anatomic area. Now, the Gorlin equation for valve area that's used typically in the cath lab uses pressure and yields an anatomic orifice area. The other thing that can be done with these cross-sectional area and VTI measurements is it can allow us to calculate shunt flow. And this has been used in patients with various types of shunts such as ASDs, VSDs, partial anomalous pulmonary venous return. So what it lets us do is calculate QP and QS. So QP, we're going to calculate flow in the main pulmonary artery. How are we going to do that? We'll again do the cross-sectional area times the velocity time interval, and we'll do these in the main pulmonary artery. And for QS, we'll measure flow out the left ventricular outflow tract. Usually it's a little easier to do in the LVOT area than at the valve level itself. So again, area, calculated in the LV outflow tract from the diameters. Again, both of these are from the diameters multiplied by the velocity time interval here. Now, over here and here, I've just expanded the area part out, and so it's pi times the diameter over 2. Diameter over 2 is of the radius. So this is the formula to get the area. And if you look at this, and you see we're going to divide QP over QS, you can see that a number of these things are going to cancel out. The pi's cancel out, the 2's cancel out, and you get this formula here. And so that can be used to calculate the QP to QS ratio. You may say, well, gosh, at my place we never do that. And if that's the case, the reason is that there's concern about its accuracy. In particular, the MPA diameter can be difficult to measure accurately, and it also varies significantly over the course of the cardiac cycle. In systole, the MPA, even more than the aorta, expands. And these diameter measurements are a little iffy, and then you can see if you look at the formula, the diameter is actually squared. So even a difference in 1 millimeter can result in a significant change in the numbers you calculate. Nevertheless, this is an approach, and it has been used in some situations. So when you think about ventricular systolic function, there's different kind of dimensions you can contemplate it over. First, the systolic and diastolic function. And as I said, we'll do diastolic function after the break. There's also, when you think about the function, you can think about it global, how well is the pump working, versus regional, how is this area of the myocardium doing compared to another area of the myocardium. And then another dimension to think about function is, are you looking at it at the ventricular level, or are you looking at it at the myocardial fiber level? So ventricular, again, thinks of it as kind of one unit, one pump, and the fiber level looks at it as individual kind of shortening, force-generating units. So for the purpose of our next little discussion, we're going to be talking about systolic function, we're going to be looking at it from a global perspective, and we're going to be looking at the ventricular level as opposed to the fiber level. So to begin with, let me just remind you of some of the determinants of global ventricular systolic function. And in the end, this comes down to thinking about fibers and what influences how well they shorten. And this shortening is load dependent, and the loads are determined by these first three things, but we also need to take into account heart rate as well. And so this is part of in this echo discussion, but it's also kind of comes up in various other things in pediatric cardiology. So the first is preload. We need to take into account preload. The more preload, the greater shortening you're going to have and the better global systolic function. So this is the Frank-Starling mechanism. You give a bolus, it expands it expands the ventricular cavity. With that, the myocardial fibers get stretched a little bit, and as a result, they shorten better. So that's the effect of preload. The second thing is afterload. That's kind of how much work you have that the ventricle has to pump against. If you lower the afterload, you improve shortening and you get better global systolic function. So lower afterload leads to better ventricular systolic function. And then there's contractility. And here we're talking about each of those force-generating units, each myocyte. How good a force generator is it? How good a shortening unit is it? And it's its intrinsic ability, independent of preload and afterload, to contract and shorten. And then finally, sometimes people forget about this, but you shouldn't. Heart rate is important as well. And at a faster heart rate, a given myofiber will shorten better. That's that force-frequency relationship you may have touched upon in medical school. So all of these things impact myocardial shortening, and the better myocardial shortening you have, the better global ventricular systolic function. Kind of stepping back from it, you can have great shortening of individual areas of the myocardium, but if they're not all contracting together, then you won't have good global systolic function. So another dimension to consider is synchrony. Are all the different areas contracting in together? And so these are the determinants of global systolic function, and we may come back to those. So what are the measures from echocardiography for global systolic function? I'm just going to go through some of the most common ones just as a review. This shortening fraction. sometimes called fractional shortening. Here's the formula. It says that, and it's expressed as a percent. So the shortening fraction is the end diastolic dimension. So we're talking about 2D dimension measurements, or a length measurement. It's the end diastolic dimension minus the end systolic dimension, and then we're going to take that and divide it by the end diastolic dimension and then multiply it by 100 because we're doing a percentage. So the normal range is about 28 to 38%. Now, when you measure these dimensions, you can do them using different echo types of imaging. You can do it using M mode or with 2D imaging. And sometimes people will use parasternal long axis views or various short axis views as well. It does, however, have some limitations that are important to mention. So first, it assumes that there's no regional wall motion abnormalities. So you're looking at a distance just at 2 locations, and you're not taking into account anything along the rest of the circumference of the ventricle. So if you have regional wall motion abnormalities, it won't be reflected necessarily in the shortening fraction. It's also less valid in the setting of abnormal septal motion, such as what you'd get during bundle branch block or when RV volume overload, when the septum is pushed into the LV as in diastole. It also reflects only circumferential, but not longitudinal shortening. You're looking at it as it goes from a big circle to a little circle, but you're not looking at that other component, that base to apex contraction of the ventricle. And then finally, it's load dependent. Your shortening fraction will depend or vary with your preload, your afterload, and doesn't necessarily tell you how good those individual myofibers are working, how good the contractility is. So you could have great contractility, but very high afterload, and you would get a low ejection fraction, even though that contractility, that intrinsic force-generating capacity of the myocytes is still intact and healthy. So shortening fraction won't tell you necessarily how good those myocytes are working. Here's an example. So this is done using M mode here. So end diastolic dimension. So we have the septum here, the posterior wall here. We're going to measure this edge to this edge. It's a distance. And then we have end systole over here. Take the difference, put it over the end diastolic dimension, and then multiply by 100. Example of good function. Here you can see there's very little contraction going on, and the end diastolic and end systolic measurements are similar. Another parameter for global systolic function is ejection fraction. Here the formula is similar to that for shortening fraction, but now instead of measuring distances, we're going to calculate a volume. So end diastolic volume minus end systolic volume over the end diastolic volume, and again we'll multiply by 100 because it's a percentage. And then another way to think about this is the end diastolic volume minus the end systolic volume. The difference between the two is what goes out of the ventricle, or the stroke volume. So you could rewrite it as stroke volume over end diastolic volume. Normal range 55 to 70%. This can be measured using M mode, 2D or 3D. Again, limitations, load dependent. It's telling you pump function, but it's not necessarily telling you the contractility or how good those myocytes are. Some of these volume measurements require an apical view, and unless you're down at the tip of the apex, you run the risk of foreshortening things and underestimating the volumes. And then finally, acoustic windows can make this inaccurate as well. If you can't see it well, it's hard to measure it well, and you'll have some inaccuracies. So here's some examples of ways to measure ejection fraction. One approach is the modified Simpson's biplane approach. So here we have diastole, here we have systole, and so what you're going to do is you get, for each of these, for both diastole and systole, we're going to measure things in 2 orthogonal planes. Here this is a 4-chamber, this is a 2-chamber view, and you put a contour around the edges of the ventricle, and the machine will put these little lines in there. And essentially what you're saying is, in order to calculate the volume here, I'm going to assume between these two, each of these parallel lines, I'm going to have an ellipse, but it has a certain thickness. And the area of my ellipse is going to be, I have a major diameter here and another diameter here, and I'm going to calculate the area of that ellipse, and then I know how thick it is, so I'm going to multiply it by the thickness, and that'll give a volume for that disc, and then I'm going to sum up all these, the volume of the disc in order to get the volume of the whole chamber. And so you do that in diastole and systole, and then you can apply the ejection fraction formula. Another approach has been to use the area length calculation. Here you use an apical four-chamber view and a parasternal short axis view. You have area, you have length, and the formula is 5/6 area times length in order to get the volume, and you do that in diastole and systole and apply the formula. And then let me mention another parameter for systolic function, because sometimes this comes up. It's called the velocity of circumferential fiber shortening. And it's not really that complicated to calculate. You just take the shortening fraction, which we mentioned before, and you divide it by the ejection time. And you can measure the ejection time by putting a pulse wave across aortic valve flow and measure the time from the beginning of the flow to when the flow ends. Or another way to do it is to look at aortic valve motion and time it from the beginning, the opening of the valve, to valve closure. And then you can say, well, let me correct that also for heart rate. So you take this formula and then just divide it by the square root of the RR interval. So in doing this calculation, this parameter has the same limitations as shortening fraction does, and again, because shortening fraction is in the equation. But the reason you're going through all this is because it does have some value, and this parameter has been shown to be insensitive to preload. So it's a way of factoring out preload. So you wouldn't expect this to change, everything else being held constant. Let's say you bolus somebody with fluid, this would stay the same. So put another way, it's sensitivity to contractility and afterload, but not preload. So if you have changes in the corrected VCF, that means there have been changes in either intrinsic contractility or afterload. And if you have a way of factoring one of these out, let's say afterload, then you're left with something that just reflects contractility. And that's its value. It's telling you that if you can get to contractility, it's telling you about the health of those individual myocytes, independent of those loading conditions. And then finally, we talked about global function. Also, with imaging modalities, you can evaluate regional function. And there are various schemas. This is probably the most common AHA classification, where the segments are named and numbered from short axis and long axis views. And the typical subjective scoring system that's applied is ranged from normal, hypokinesis, akinesis, dyskinesis, and aneurysmal, where things are thin-walled and bulging out. So again, we'll begin with some background just to make sure everybody's on the same page, and then I'll come with a way of summing it up and how to interpret diastolic function. So let's talk about diastole. One perspective on this is to divide diastole up into 4 different phases as you move across diastole in time. So here the ventricle is in systole, it squeezes, it's finished systole, and then what first will happen is that the semilunar valve will close. So that valve is closed. You haven't yet had the mitral valve, for example, opening up. So there's a period of isovolumic relaxation when the semilunar valve is closed, but before you have onset of AV valve flow. The next phase of diastole is rapid filling. So now the AV valve opens, the atrial pressure is larger than the ventricular pressure. In part, this is because as the ventricle relaxes, it creates a bit of a suction effect. And so with atrial pressure higher than ventricular pressure, blood flows in through the mitral valve, and on pulse wave Doppler, looking at mitral valve flow, that's what creates this E wave, E for early. Then as blood comes into the ventricle and starts coming in, that increases the left ventricular pressure and decreases the left atrial pressure. So you get some pressure equilibration, flow slows down, and you have this moment of diastasis where you have equal atrial and ventricular pressures and little flow. And then the fourth phase comes with atrial contraction. So atria squeezes, that increases the atrial pressure again and forces blood into the left ventricle, and that's what creates this A wave, A for atrial, on the pulse wave trace. So that's one approach to thinking about diastole. Another approach is to think about 2 different processes which occur. One is ventricular relaxation, and you can think of this as how pressure decreases over time during diastole. And this ventricular relaxation part, you might think, okay, the ventricle's done squeezing and then it just stops. But in fact, there's an active energy-dependent process to deactivate the ventricle and make it relax. So the contractile elements need to be deactivated. That takes ATP, some energy to do that. This process, this ventricular relaxation, this is thought to be one of the first things to become abnormal when you start developing diastolic dysfunction, so you get poor relaxation. The other diastolic process to think about is chamber compliance and how that's related to how flow comes into the ventricle. So here you can think of the chamber, the muscle, as kind of a balloon, and how well it fills, how easy it is to feel, the mechanical properties of that balloon or myocardium. So you get poor chamber compliance or worse chamber compliance when you have myocardial stiffness. But in addition, if you have something outside the heart that makes it hard to fill, such as some sort of pericarditis, constricted pericarditis, or if the ventricle is operating far out on its pressure volume curve, so very dilated ventricle, all those things can lead to increased myocardial stiffness. So when you're at that state where you have high stiffness, poor compliance, any time you send some extra blood and try to force it into that ventricle, the pressure is going to shoot up. And so that impaired compliance leads to increased sensitivity to preloads, for example, fluid bolus and things like that. So we have these two processes. So now let's kind of look at how we evaluate diastolic function by echocardiography. I've listed here some of the main parameters that people evaluate in order to gain some insight into diastolic function. It's the pulse wave Doppler at the AV valve inflow, pulse wave Doppler at the pulmonary vein, pulse wave tissue Doppler at the AV valve, and then you can also look at atrial size. And the idea behind looking at atrial size is that this helps give you an idea about the duration of diastolic dysfunction, because if it's a very short term and it hasn't been going on for a while, then you tend not to have atrial dilation. But if it's occurred, if it's chronic, then the left atrium tends to be larger. Also, the degree of the size or the enlargement can give you some insight into the severity. And then finally, certainly for left-sided or left ventricular diastolic dysfunction, taking a look at RV pressure estimates is also important, because if you have a high filling pressure in the left ventricle, that'll back up into the left atrium, into the pulmonary circulation, and then into the right ventricular side. And so in severe diastolic dysfunction, you'll get elevated right-sided pressures as well. Okay, so let's look at each of these in a little bit more detail, particularly the Doppler indices. So this is what pulse wave Doppler of the mitral valve inflow looks like. Again, E wave, A wave. And the other parameter or analysis of this I'm going to add now is the deceleration time. That's how quickly you go from the peak E wave down to the baseline. So if it's a slow deceleration time, it would look more like this, and a rapid deceleration time, it just drops down even faster. So we're looking at the slope there. Here's a look at the pulmonary vein pulse wave Doppler trace. So forward flow is above the baseline, backward flow in the pulmonary vein is below the baseline. So typically you have a peak in systole, we have forward flow in the pulmonary veins, and then another peak in diastole. And then as the atria contracts, the blood has a choice. It can go in through the mitral valve, or it can back up or reflux through the pulmonary vein. And so typically you have a little bit going backward in the pulmonary vein, and that's the pulmonary vein A wave. People will sometimes look at this A wave, particularly its duration, so it would be its width, since we're looking at time along this axis, to gain some insights into diastolic dysfunction. But normally, the duration of the mitral valve A wave should be longer than the pulmonary vein A wave, so you shouldn't have a very long or prolonged pulmonary vein A wave. Here's a look at the pulse wave tissue Doppler now, done at the valve annuli, either the septum or the lateral wall there. And you can see an E wave and an A wave, and because it's pulse wave Doppler, we're looking at tissue Doppler now as opposed to looking at mitral inflow. It's given this, the mark up here, to distinguish it and to let you know it's a pulse wave Doppler. Sometimes other terminology uses a little subscrape down here, but here they use the little prime signals, and that's probably more common. So you have the E prime and the A prime. So this diagram kind of puts everything all together, and so I'm going to spend a couple of minutes on it just to walk you through it. So here we have some indices. I've simplified some things, but I think this will work for you. You can see I rounded things to 10 in a lot of cases, but I do think that will work. And here we're seeing the different wave traces. So this is mitral inflow, this row is pulmonary vein flow, and this is the tissue Doppler at the annuli here. So normal, you can look at the mitral valve inflow and look at that E wave to A wave ratio. So we're just looking at how tall they are and taking the ratio of them. And normal is for that to be approximately 2. The deceleration time is usually between 100 and 200. Pulmonary A wave duration is normal, in other words, less than the mitral valve A wave duration. The E prime value, that tissue Doppler parameter, usually greater than 10. And the E over E prime. So we're taking the pulse wave, E wave, and dividing that by the tissue Doppler, E prime wave. And if you look at that ratio is usually less than 10. So this is what you see in normal. And then, as I mentioned earlier, often, or at least according to this paradigm, one of the first things to go abnormal when you're developing diastolic dysfunction is to have abnormal relaxation. So that's that active process where the ventricle needs to go from systole and start relaxing into diastole. When that happens, the amplitude of the E wave on the mitral valve inflow decreases. In addition to that, the deceleration time, this slope here, becomes prolonged. And I think that makes some sense because now the ventricle can't relax as easily, and because of that you get less flow in, and that flow that does come in comes in over a longer time, so it slows down. Now, you have less blood flow coming in during the early part, and then during the late part, in order to kind of make up for that the less blood flow that came in the early part, you have an increase in the A wave. So the A wave tends to get a little bit larger. As a result, E is smaller, A is bigger. This E to A ratio is now less than 1. Pulmonary vein A wave duration generally stays normal. E prime on the tissue Doppler has now decreased. This was normal. It's now lower amplitude, so less than 10. And now, if you look at that E to E prime ratio, that's still less than 10 here. Okay, because this got smaller, but this one got smaller as well, and the ratio still stayed less than 10. All right, and then the next thing that happens, we're going to skip over pseudo-normal for a second and go when you get to this more restrictive pattern. So now we're talking about the more severe end of diastolic dysfunction, where not only do you have abnormalities in relaxation, but you also have a very non-compliant stiff ventricle as well. Okay, in those cases, let's take a look at what happens to the mitral valve inflow. Because the ventricle is so stiff, that pressure in the left atrium has been driven higher and higher. So now, as soon as that mitral valve opens, you get a rush of blood in, so that the E wave on mitral valve inflow has become quite large. Okay? It was small back here during abnormal relaxation, but now, because there's higher left atrial pressure, more driving force, it's increased. In addition to that, the deceleration time, the slope here, the deceleration time has decreased. And one way to think about this is you now have a very high filling pressure in the left ventricle. The mitral valve opens, you start pushing blood into the left ventricle, but because that pressure is high, it's almost like that blood is running up into a wall, and so it decelerates very fast. And so now the deceleration time is quite short. If you look at the pulmonary vein A wave duration, that has now become increased. Again, the atria contracts, the blood has a choice into the high pressure left atrium or maybe reflux back through the pulmonary veins. Now, because that LV pressure is so much higher, some is going to reflux backward, and that will increase the duration. And then if you look at the E prime remains abnormal, it's low here as well. So if you look at the E to E prime ratio now, this became taller, this stayed small, the E to E prime ratio is now increased in this restrictive pattern. All right, so now I'm going to try to explain this pseudo-normal in-between category and why it's even there. So if you just focus on this column and accept the fact that you progress from this over to this, you can imagine at some point here the E wave is less than the E wave, here the E wave is greater than the A wave. At some point there's going to be an in-between situation where it looks like this as you're working your way up to even higher E wave peak. The problem here is this kind of looks like the normal. But however, it's not normal. You're in your transition from this abnormal relaxation phase to this restrictive phase. So the question then came up, well, if I see this type of mitral valve inflow, this E to A, how do I know whether it's the normal or whether it's this pseudo-normal on the way to restrictive? And so there are some indices that can help you distinguish that. In particular, the keys are the pulmonary vein A wave duration is increased. You can kind of see that shown here. This is wider than it is here. And in addition, the E prime is abnormally small, less than 10, whereas in normal it's greater than 10. And you can see that here versus here. So it's this and this primarily that help you distinguish this pseudo-normal pattern from real normal over here. Let me go into this with just some examples to help kind of solidify the point. Here we have a mitral valve inflow tissue Doppler trace. This is illustrative of abnormal relaxation. Again, you can see the decreased E wave because, again, the relaxation, that early phase isn't working as well, so not as much blood comes in, and it also comes in more slowly because the ventricle's having a slower time to relax. Just parenthetically, you can also see this same pattern where E is less than A in a normal fetus and in some newborns as well. Let's look at a pseudo-normal pattern here. I'm giving you the mitral valve Doppler, the pulmonary vein Doppler, and the tissue Doppler indices. So again, we've got increased LV stiffness at this point, and an increased LA pressure that's driven the E wave up more in the mitral valve inflow, but this E to A still, that could be close to normal. So how am I going to distinguish that from normal? Well, I'm going to look at the pulmonary valve A wave duration, and you can see it there, and if you measure it out, this duration is bigger than this duration here. And in addition to that, I'm going to look at the E prime velocity, and here it's decreased. And then the E to A ratio is also abnormal at greater than 10. And finally, an example of the restrictive pattern. Here, things have gone even more awry. The LA pressure is even higher. So the mitral valve opens and you get this big rush, a high amplitude E wave. By the time it's ready for atrial contraction, the ventricle's at very high pressure, so the atria can contract, but not much comes in. So you have this very elevated E to A wave. In addition, the deceleration time of the E wave is now quite short, less than 150 milliseconds. Again, that's that blood running into a wall kind of phenomena. Pulmonary valve A wave duration stays prolonged because, again, the blood has a choice, forward or reflux back, and more will reflux back given the high filling pressure in the left ventricle. And then you get this markedly reduced E prime here. Again, going along with diastolic dysfunction, and the E to E prime ratio, again, high E, small E prime, and as a result, that ratio is quite large now. So then finally, just a few age-related changes. As I mentioned, for the fetus and infant, you tend to see decreased early filling, so you have a reduced A wave, and the E to A wave can be low for both ventricles. And some people have interpreted this to mean that the fetal myocardium is immature and has abnormal diastolic properties. Someplace at around 2 months of age, you tend to see a trend toward normalization where the E is greater than the A. And then also in young children, it's rare to see any A wave reversal on the pulmonary vein. All right. Let me go now to the next section of our discussion here on echocardiography. We're going to talk about special techniques. We'll begin with TEE. And I don't have any great way of going through the indications other than listing them for you, and I'll say them out loud just so you have a chance to hear them once. I think a lot of these will be intuitive for you. First indication, inadequate transthoracic echo in a patient with known or suspected congenital heart disease. So the inadequate transthoracic studies tend to be in larger patients. That's a sufficient indication for you at least to consider to do a TEE to get more ultrasound or echocardiographic imaging information for your patient. Another one is evaluation for possible right to left shunting in a patient being evaluated for stroke or being considered for a transvenous pacemaker insertion. This part is because transvenous leads might form a clot, and you want to make sure or see what their risk of them having a paradoxical embolus is and how that relates to right to left shunting. Again, number 3, examination for vegetation, abscess or central line infection. The idea behind this is the acoustic access and the picture clarity will be better by TEE and give you better sensitivity to detect these problems than just transthoracic echo. Examination to evaluate for thrombus prior to cardioversion, same story, better sensitivity. You're all familiar, I think, with number 5, intraoperative evaluation to assess the patient and the adequacy of the surgical repair, as well as for hemodynamic monitoring of the patient as they're recovering or during the procedure. And number 6 is guidance during a catheterization procedure, such as ASD or VSD closure or paravalvular leak, and to guide transseptal puncture. So I've listed here absolute contraindications and relative contraindications. Absolute, unrepaired tracheoesophageal fistula, generally considered an absolute contraindication. Esophageal obstruction, again, it's a transesophageal probe. It's got to go down the esophagus, past the obstruction. So that would be considered a contraindication. Poor airway control is the idea that if your patient has a marginal respiratory status, sticking something else in the oropharynx that can potentially compromise or compress the airway is not a good idea. And then uncooperative, unsedated patient, if the patient's thrashing around with this tube down their esophagus, that's not a safe situation. So you need to have the patient at least have some measure of cooperation or be sedated in order to do this. Relative contraindications, previous esophageal surgery with possible residual obstruction, esophageal varices, a vascular ring or anomaly that could produce airway compromise, severe coagulopathy. Now, again, we do TEEs all the time with patients anticoagulated while they're on bypass, but at least should be something to be considered. And again, it would have to be at the severe end for you to be particularly worried about it. And then cervical spine injury or instability. Again, when you place the probe and are manipulating the probe, there's a chance that you could move the head and neck, and so you'd want to know and think twice about that before you proceeded. Risks and complications of TEE, airway compromise. So this can be compression, and this never happened to me, but there is the potential that as you're moving the TEE probe in and out, you might also move the endotracheal tube in and then push it down and result in right mainstem intubation there. Again, inadvertent tracheal extubation, you're working around the mouth there, and the endotracheal tube may be in the mouth as well, and so you got to be aware of that. Esophageal injury, dysphagia, bleeding, loss of... People love this one, and I guess it does make for a reasonable test question because it combines things, but some anatomy and some physiology and some imaging all into one question. But loss of upper extremity pulse with compression of an aberrant subclavian artery. So aberrant subclavian arteries go retroesophageal. Your probe is going down the esophagus, so you may compress that aberrant subclavian artery, decreasing blood flow through there and leading to loss of pulse in the extremity, the upper extremity that's being supplied by that subclavian artery. So it could be from an aberrant right or an aberrant left, depending on the anatomy. Hypotension, this is typically from compression of the descending aorta by the TEE probe. Similarly, you can increase the left atrial pressure from compression and pulmonary veins as well. And then if you go through these things, most of these things are more common in smaller patients where just the space is tighter and there's more chance for compressing or obstructing something with the TEE probe. Limitations for TEE. TEE is good for some things, particularly looking inside the heart, but in the end, that probe can either be in the esophagus or be in the stomach, and unlike transthoracic, where you can kind of move around all over the chest and get different views on things, you still are fairly limited to where that probe can be. Another way of saying this is you can't always align things with the flow signal and get proper Doppler alignment for measuring gradients and things like that. You're also kind of a fixed distance away from structures, so you can't really adjust to that. Sometimes the anterior structures, the ones closer to the anterior chest wall, are too far from the probe and hard to see. Sometimes things that are right close to the probe, like pulmonary veins, are almost too near, and they can be hard to resolve from time to time. In the upper chest, the left pulmonary artery and the blood vessels in the upper chest, such as the aortic arch, can sometimes be hard to visualize. And the IVC-RA junction can be a little bit of a blind spot by TEE as well. I included this just on the off chance that there could be TEE pictures in the test. I'm just going to give you or remind you of some ways to orient to them. So the TEE probe, if it's not in the stomach, it's in the esophagus. And the esophagus, if the anatomy is roughly normal, is going to be behind the left atrium. So where you see the marker, the thing that's going to be closest to that marker is usually going to be the left atrium. Again, assuming there's not unusual anatomy or situs inversus or things like that. So this is a 4-chamber view, and you can see we're kind of in the horizontal or transverse plane, and this is rotated more closer to 90 degrees. But in either case, the left atrium is the structure closest here. And then right is still over on this side of the screen as it would be for transthoracic echo. Left is over on this side of the screen as it would be for transthoracic. And then when you go to these kind of long axis 90-degree type views here, head is usually over on this side, so the right side of the screen, and feet are over here on the left side of the screen. You see SVC, right atrium, and IVC would be over here, and this is atrial septum. All right, let's move on and talk about contrast echocardiography. We'll talk first about contrast agents, just briefly. So by far the most common contrast agent to use would be agitated saline. You take the saline, you put it in a couple of syringes with a stopcock, swish it back and forth, and you can make little tiny microbubbles. These bubbles are filtered by the normal pulmonary circulation as it goes through the capillaries. So it can make it through the big arteries, but when it gets to the small vessels, like the equivalent of going from highway to small streets, the bubbles are filtered out again, typically in the lung. Another class of contrast agents would be what are called LV blood pool agents. These are small enough to pass through the normal pulmonary circulation, make their way through the capillaries, and so they make it around to the left side of the heart, and these can be used for better LV visualization. Last time I checked, though, these aren't approved in children, so this is really going to be the focus of everything I say from here on out, the agitated saline. So again, you create these little microbubbles, and these are reflect the sound waves, so they show up bright, and you can follow them through the circulation. The uses for an agitated saline or contrast echocardiogram are shown here. They can be used to detect a PFO, in particular the right to left shunt that could be associated with a PFO. I'll have more to say about this one in a minute. Another use is to aid visualization of systemic venous drainage. For example, if you suspect the patient has a left superior vena cava to an unroofed coronary sinus, in other words, the LSVC drains directly into the left atrium, one thing you could do is get an IV into the left arm, inject some agitated saline, and show that the contrast first appears in the left atrium and then makes its way over into the right atrium. Another use is to detect intrapulmonary arteriovenous malformations. So in this case, now you have pulmonary vessels that don't break down into tiny capillaries but stay relatively large. The AV malformation part, those are relatively large vessels, and so they won't filter out the contrast, and as a result, the contrast will not be all be filtered out by the lungs, and some will make it over to the left side. Another use of contrast is you give your bolus of contrast and it puts this bright signal into the right ventricle, and that can sometimes help you visualize the borders of the right ventricle and see wall motion better through that technique. And in a related application, it also makes the TR jet signal brighter, again, because it's made higher amplitude, because the blood that's being sent backwards has these bubbles in it, which just gives it a stronger signal. And then finally, some people have used it to help visualize a catheter or a needle tip location. For example, if somebody has an intracardiac line and you're not sure whether it's inside the heart or inside the pericardium, you can agitate some saline and put a little bit, not a lot, a little bit through there and see whether the bubbles show up inside the heart or in the pericardial space. In terms of complications, these are all very rare, but people have reported TIA or stroke, myocardial ischemia, presumably from bubbles making it over to the left side and down the coronary arteries. And then since we're injecting through an IV, there's a chance for an IV to infiltrate. A few more words on the PFO right to left shunt detection application. So for normal people, you shouldn't see any contrast make its way over to the left heart. It should all go right atrium, right ventricle, into the pulmonary arteries and get filtered by the lungs. If you have positive left heart contrast, so bubbles made its way into the left heart, left atrium, left ventricle, aorta, that indicates that there's a right to left intracardiac shunt or that there's pulmonary AVMs. And one rule of thumb, so not 100% reliable, but a rule of thumb that helps you distinguish between the two of these, AVMs versus an intracardiac shunt, is if the bubbles appear in the left side relatively quickly, after 3 to 5 beats, after that right atrial opacification, that suggests that the shunt is intracardiac. If it takes a little bit longer than that, approximately greater than 5 beats, that would suggest that it's made its way first to the pulmonary arteries and then through the lungs. So it's a longer road, so therefore it takes longer to show up in the left heart. That suggests pulmonary AVMs. Another way to see that it's pulmonary AVMs is to see the bubbles actually be coming through the pulmonary veins, which suggests it made its way through the lungs. To have the best sensitivity to detect a right to left shunt, you want to employ some maneuver to make the right atrial pressure bigger than the left atrial pressure. So just because you have a PFO there and you put contrast into the right atrium, if the left atrial pressure is bigger, even if there is a PFO, that contrast won't be pushed across the PFO. What you want to do is do something to elevate the right atrial pressure so that the contrast, if there is a PFO, will be directed across it. And those maneuvers include Valsalva maneuvers or cough, something to increase the right atrial pressure. And then finally, the general point about PFO and right to left shunt detection is that TEE is more sensitive than a transthoracic echo. So what I have here is an example. It's a pretty clear-cut example of a positive study. You can see the contrast coming in, appearing bright on the right side, and then making its way around to the left side. And this is very dense opacification. This patient had a lot of pulmonary arteriovenous malformations, and that's what led to this very dense opacification over on the left side. You can also appreciate for this, just as a side point, how having the contrast in the right ventricle maybe helps you see the borders just a little bit better. All right, last, let me talk about stress echocardiography. So you have to talk about what kind of stress you're going to use. Your choices are an exercise stress versus a pharmacologic stress. With exercise, you then have a choice. You can typically do treadmill or bicycle. Exercise is typically preferred over pharmacologic stress because it tends to be a better stressor and also tends to mimic more of what people do in their everyday life. Pharmacologic stress is typically done with dobutamine, and sometimes people will add atropine as well. For either type of stress test, there's often a target heart rate or a rate pressure product. A rate pressure product just means heart rate times the systolic blood pressure. That's an indication of just how much extra work you're asking the heart to do. When you do this stress echocardiogram, you're going to evaluate regional and global ventricular systolic and diastolic function. You can use it to evaluate valvular function and pulmonary artery pressure. Specifically, I'm going to just list here what the indications are for stress echocardiography. Maybe one of the more common ones is coronary artery disease. It's both used for diagnosis as well as risk stratification. You're trying to determine the presence and extent of ischemic myocardium as well as viability. Here again, the mechanism of stress is either through exercise or pharmacology. We're increasing the myocardial oxygen demand, and we're going to see whether the blood supply can keep up with it. If there's a significant coronary artery stenosis, less blood, less oxygen delivery, there'll be an imbalance and dysfunction will develop. So visually, you're looking at the endocardial excursion as well as wall thickening, and a positive test would be if you see the development of reversible wall motion abnormality. Typically, things look okay at rest. You stress them, you get some decreased motion, and then they go back to rest and the motion recovers. And you can also look at wall thickening, ejection fraction, and the end systolic volume. If the end systolic volume is going up with stress, that's usually a sign of an abnormality. The reason you would do this is that, so one type of stress test is just to put people on a bike or a treadmill and look for EKG changes alone. But if you couple that type of stress with imaging as well, that leads to better accuracy for the detection of coronary artery disease. So stress with imaging, better accuracy than a stress test with EKG alone. And then just a general statement, if you compare stress echocardiography versus some of the nuclear perfusion techniques, stress echo tends to have slightly better specificity and worse sensitivity. It does have the advantage of being cheaper and doesn't have any ionizing radiation exposure compared to the nuclear options. Other indications for stress echo, very briefly, we'll go through these. Patients who have dyspnea, but it's dyspnea only on exertion, and you're wondering whether there's a cardiac origin, it seems to make sense. Let's mimic the situation where they're getting their symptoms, namely exercise or exertion, and so you can evaluate their heart under that state. Pulmonary hypertension, there is a subgroup of patients out there with pulmonary hypertension who have a normal pulmonary artery pressure at rest, but then it becomes markedly increased with exercise. So that's an indication for stress echo. Mitral valve dysfunction sometimes can become significantly worse during exercise. Aortic stenosis, if your patient has ventricular dysfunction and therefore a lower output, sometimes you can get a relatively low gradient. And again, this goes back to the fact that the orifice is anatomically severely small, but you're not sending a lot of flow across it, so you might only get a gradient of 30 or 40. But if you can improve their output, you'll then kind of unmask the stenosis because the gradient will go up, and you'll therefore be able to properly categorize it as severe stenosis. And then hypertrophic cardiomyopathy. Some patients might be symptomatic, but they don't have any LV outflow tract obstruction at rest, but with exercise, they'll develop subaortic obstruction, and this is exercise stress echo as a way of distinguishing and determining that for your patients. Safety risks of stress echocardiography, arrhythmia, atrial fibrillation, SVT, bradycardia, VTVF, severe systemic hypertension. Some patients will have a hypotensive response to exercise. If you're doing this in the setting of possible coronary artery disease, there's a chance you could overstress them and provoke a myocardial infarction. If you look at the complication rates for life-threatening events, exercise stress, quite low. Dobutamine stress has a higher complication rate, and that's primarily because the dobutamine can induce some of these arrhythmias that come with, can sometimes, particularly the VT and VF, associated with a life-threatening event. All right. For the remaining time, I'm going to go through some examples of echo with a little bit of commentary. You can kind of think of this as echo flashcards just to provoke your thinking and remind you of a few things. So one of the things the board likes to do is make sure you know normal. So we'll start out with this. So this is a subcostal view. You can see the IVC, the SVC in the right atrium. This structure here is normal. This is the eustachian valve. Remember, you have the IVC coming in, the atrial septal wall is here, and the eustachian valve is, if you will, on the other side of the IVC, on the left side of the screen, or left and low here. Secundum ASD, subcostal view again, left atrium, right atrium, medium-sized defect. You can see the left to right flow across that. I think that's pretty straightforward for most of you. You can just compare and contrast that to this. This is an example of a sinus venosus defect. Again, subcostal view here. SVC coming down. This is the atrial septum, and the atrial septum itself is intact. Just this shared wall here between the right upper pulmonary vein and the SVC that's missing. So you can see this is more superiorly positioned. The secundum defect would have been over here. And again, you can see it with color flow. Here's another version of a superior sinus venosus defect. Now we're looking at a parasternal view. This is a parasternal right sternal border view. So dots at 12 o'clock. We're over a little bit to the right of the sternum to get this. SVC, RA, LA. This is right pulmonary artery and cross section, and here's the defect between here, and the rest of this is atrial septum, LA, RA. All right, primum ASD. Here you can see on the apical view, the defect here, kind of confluent with the crux of the heart right in here. You can see that the hinge points of the AV valves here are now at the same level. As opposed to normally the tricuspid valve hinge point would be more apical. The mitral valve hinge point, you can see it's confirmed by color Doppler. You see the right atrial and right ventricular dilation. And then you see the mitral regurgitation, and as many of you know, primum ASD is also associated with a cleft mitral valve, and you can see an example of that over here. So normally the mitral valve would just have a coaptation like this. Now it has this triangular shape. Here's an image. I left it as a still image just to make it easier to discuss. This is a parasternal short axis view of the aortic valve and root here. And you can see this is right ventricle over here. This is going to be pulmonary valve, aortic valve here, left atrium, right atrium here. And normally this would all be intact. This is a ventricular septum. When you have a defect here adjacent to the pulmonary valve annulus, it's a conal septal VSD. Unfortunately, this defect has at least 4 other names that many of you are familiar with. Sometimes it's called a doubly committed VSD, sometimes supracrystal VSD, and there are others as well. A membranous VSD would be over here on this side. Okay, so the conal septal VSD is over on close here to the pulmonary valve. Membranous defect here is around on this side, close to the tricuspid valve. This is an example of a patent ductus arteriosus, a typical kind of ductal view over on the high left chest, the dot at 12 o'clock. Just to remind you of the anatomy, MPA here, aortic arch coming around like that, and here's the ductus going from the pulmonary artery end into the aorta. If you look on the color Doppler, you can see this bidirectional flow here. Let's just look at some of the color Doppler, or pulse wave Doppler patterns you can have in the ductus. So you can have continuous left to right. So if it's going left to right throughout the cardiac cycle, that's usually indicative of a low pulmonary vascular resistance. You can have it go right to left. And when it goes all right to left like this, it's right to left in systole. Okay, this is indicative of a very high pulmonary vascular resistance. And then you can have kind of in between these two this bidirectional pattern. And when it's bidirectional, it's going right to left in systole. So right to left is MPA to the aorta, and then aorta to the PA, or left to right in diastole here. And this is an elevated pulmonary vascular resistance, but not as elevated as this is. Example of total veins to the coronary sinus. Here you can see on the 2D subcostal view, you have right atrium, left atrium is in here. This is the atrial septum. You can see the PFO here, between here and here. And here we have the pulmonary veins draining to a confluence, and that confluence is draining to the coronary sinus. And then this is the os of the coronary sinus here, draining into the right atrium. Some people like to call this a whale's tail here. You can kind of see the whale, there, tail, head, the eye would be there. Anyhow, good example of that. Different type of total veins. If you see a picture like this, confluence to the back of the heart here, and then you see this vessel that's running vertically, and with the color Doppler you can see it's running up toward the head. That's a good sign that this is total veins, and this would be the supracardiac version of it. Here's an example of quartre atriatum. So right atrium, right ventricle, left ventricle. Here we have a pulmonary venous confluence here, and here's the left atrium, and it's kind of bisected here by this core triatriatum. I'll call it a membrane in this case, and there's a little orifice here. So pulmonary veins come in here, the blood has to squeeze through the core triatriatum membrane into the left atrium here, and then across the mitral valve. Just a reminder that the left atrial appendage is usually on the ventricular side of the core triatriatum membrane here. You can compare and contrast this to a supramitral ring. Here you can see it in 2Ds. Here's the mitral valve. Here's a supramitral ring or supramitral membrane here. In this case, the left atrial appendage would be on the atrial side of this lesion here. Again, over here, the left atrial appendage was on the ventricular side of the membrane. And you can see this is leading to mitral stenosis. Example of supravalvular aortic stenosis. Here's the valve opening up. You see the ridge of tissue at the sinotubular junction, most commonly associated with Williams syndrome. Example of Epstein abnormality. Here you can see right atrium, the atrialized portion of the right ventricle. The valve has been displaced, the effective valve down here apically, and you can see the tricuspid regurgitation. Example of a complete common atrioventricular canal. See the primum ASD, the AV canal type VSD over here, and the common AV valve. And then in the cross section here, you see that it's a common AV valve. It opens up and it's got some attachments to the septum as well. And associated with this is this gooseneck deformity. Over here, the left ventricular outflow tract is elongated, and this is kind of a common morphologic feature of a complete AV canal. Here's an example of tetralogy of Fallot, subcostal views here. So left ventricle, right ventricle. Here's the subaortic region, and you see there's a VSD here. In addition to that, this conal septum, instead of kind of curving around nicely here, is anteriorly deviated into the right ventricular outflow tract, causing some subpulmonary stenosis. And if you look at other views, you can see the aortic override of the ventricular septum, and over here, a hypoplastic doming stenotic pulmonary valve. Here we're sticking with tetralogy of Fallot, but it's mostly to show you an example of what a Doppler trace looks like with fixed and dynamic obstruction. Here you can see kind of two envelopes here superimposed on each other. Here the dynamic obstruction has a later peak because it's developing later in systole. So as the ventricle contracts, it's continuing to narrow the outflow tract, and that's why that obstruction becomes most severe toward the end of systole. The fixed obstruction has this envelope here and has this earlier peak here versus here. Okay, you can see the same thing on the left side too when you have both fixed and dynamic obstruction. Example quickly of truncus arteriosus. So as you sweep through this from subcostal view, you note that there's only one semilunar valve. It means that it could be truncus arteriosus. Another possible thing in the differential diagnosis would be pulmonary atresia. However, when you look at these sweeps, we go back to this, you can see over here you have a pulmonary artery arising from the truncal root. I'll let it go around again there. If we rotate the transducer about 90 degrees, again, you can see the single semilunar valve overriding the VSD, and then the pulmonary artery coming off posteriorly here, and there's the ascending aorta as we go through. Here's an example of transposition, subcostal sweep. So this is we're now anterior, the right ventricle's over here, here's the left ventricle. And you can see, I'll let it come around again one more time. If you follow the left ventricle, it goes out to the semilunar valve, goes up to this great vessel, and this great vessel is bifurcating into a right and left pulmonary arteries. So LV going to the PA. Similarly, you have the RV going up to the aorta, and you get a little clue that it's the aorta because if you look closely, you can see a little coronary artery coming off over here. So transposition from a subcostal view. Here's kind of one of the hallmarks of transposition. You've got the aorta and the pulmonary artery. and you can see that they're running in a parallel course. So parallel great vessels, often associated with transposition. Just a couple examples of coarctation. Here you have a discrete narrowing at the isthmus. You can also have this more diffusely hypoplastic transverse arch. Some of the Doppler patterns that you can see with coarctation, if you look at the isthmus, instead of it having a normal up and rapidly declining Doppler trace, you can see this delayed upstroke to the peak and a prolonged downstroke here, where you have persistent antegrade flow throughout diastole, consistent with a significant obstruction. If you look at the descending aorta Doppler trace, again, a blunted upstroke, a prolonged downstroke, and continued flow into diastole. Here's an example of Al Kappa. So if you're presented with severe dilation and dysfunction, certainly something to think about. You can see severe dilation and dysfunction there. And then over on the color Doppler image, we have aorta, main pulmonary artery, pulmonary valve, and you can see this coronary artery connecting to the main pulmonary artery here. So anomalous origin of the coronary artery from the pulmonary artery. Left coronary artery from the right sinus. Here we've got a moving picture. So this is the aortic valve in cross-section. The intercoronary commissure is located over here. So this is the right sinus. This is the left sinus. You can see as it scrolls through, you have a normal right coronary artery. The left coronary artery is coming off, going between the pulmonary root and the aortic root, and coming up and originating from the right sinus here. And you can see that confirmed with color Doppler. Example of a double aortic arch. So one of the tip-offs for this is you kind of get this symmetric branching of the aortic arches. So there's a right arch and a left arch, and you can see the subclavians here, and the carotids here and here come off in a nice symmetric mirror image fashion. Here's another view a little in a different orientation showing the right arch and the left arch, and you can see color going around both arches. But that symmetric origin of the head and neck vessels there is a tip-off to a double arch. Example of hypertrophic cardiomyopathy. Here you can see the severe thickening of the basal and mid-septum here. In addition, this patient has systolic anterior motion of the mitral valve, which is commonly associated with hypertrophic cardiomyopathy that has left ventricular outflow tract obstruction. You can see normally in systole, the mitral valve should fold up back here and stay out of the way of the left ventricular outflow tract. Instead, it's moving up into the left ventricular outflow tract and in fact banging into the hypertrophied septum there. So systolic anterior motion of the mitral valve. That's the 2D version of it. Here's the M-mode version of it here. So we're going along, mitral valve is open. Okay, so we're in diastole, and then we're going into systole, and you can see the posterior leaflet here being pulled up anteriorly here, and the anterior leaflet staying up there. A normal would be to have just a line over here, not up into the outflow tract where the two leaflets are coming together. Hypertrophic cardiomyopathy, often associated with left ventricular outflow tract obstruction, subvalvular aortic stenosis, and you get this dynamic left ventricular outflow tract pattern on the Doppler. So if you had valvular stenosis, it wouldn't be as late peaking or dagger shape. It would be more symmetrical. It would come up like this and down like that and have more of a U shape. Here you see a relatively late peak showing you its dynamic obstruction. Still image here showing you an example of restrictive cardiomyopathy. One of the features here is that you get dilation of both atrium. Often the atria are bigger than the ventricles, and that's related to the elevated filling pressure here. And that's a good tip-off that somebody is trying to show you a case of a restrictive cardiomyopathy. Sometimes called a Mickey Mouse heart because you have the atria here look like the ears of Mickey Mouse. Here's an example of rheumatic heart disease. Often the mitral valve is involved here, and it's got this kind of hockey stick shape appearance of the mitral valve leaflets, particularly the anterior leaflet here. See how it curves there and that can be associated with mitral stenosis and mitral regurgitation. Example of a patient with cardiorhabdomyomas. So you can see in its four-chamber and subcostal view, you've got multiple tumors in the ventricles. Anytime you see multiple tumors like this, good bet that it's multiple cardiac rhabdomyomas, and as you may recall, that's associated with tuberous sclerosis. Example of cardiac tamponade, okay, large effusion, not subtle. Okay, here's a heart banging around that can lead to alterations in the voltages on EKG. And here's an example of what you can see in tamponade physiology, where here's the right atrial wall. Normally it would have a contour like this, but you can see right atrial wall collapse. It's bowing into the right atrium during expiration. In inspiration, you're generating a negative pressure in your chest, and that's causing increased systemic venous return, so more blood comes into the right heart, including the right atrium, so that would tend to increase the right atrial pressure and push the wall into a normal position. But in expiration, you don't have that increased venous return, so that if you have extra pressure out here, that will bow the right atrium in, and so that's why this occurs during expiration. And then finally, with cardiac tamponade, what you see on the pulse Doppler trace is an exaggeration of the normal respirophasic variation in flow. So it's normal as you breathe in and breathe out to see some variation in the tricuspid valve inflow and mitral inflow and aortic outflow. But when you have tamponade, those changes are exaggerated or increased. So in the setting of tamponade, tricuspid valve inflow, the E wave will increase by roughly greater than 50% during inspiration. And again, it's normal for the tricuspid valve inflow to increase when you take a breath in, but because there's a pericardial effusion that's constraining the heart, that increased blood flow, all it can do is kind of pull over and increase the amplitude of that tricuspid valve inflow. At the same time, on the left side of the heart, you'll see a decrease, typically greater than 30% during inspiration. And what's happening there is you're taking a deep breath in, you're increasing the filling of the right heart, that ventricular septal position bows into the left ventricle and impedes its ability to fill. And that's why you see a decrease over on the left side of the heart. So that brings me to the end of the examples. I believe we're right on time, and let me pause here. And I think the next set is the next thing to go through the question and answers and the audience response. All right, I will read the question out loud. You are performing an echocardiogram on a 10-year-old boy with aortic regurgitation. In order to increase the 2D imaging frame rate to better visualize the mechanism of regurgitation, which of the following adjustments should you make? A, decrease the transmit gain settings. B, decrease the image depth. C, widen the image sector. D, increase the line density. C, lengthen the image focal range. So we're looking to increase the 2D imaging frame rate. Good. All right. And B is the correct answer. Good. So let's just go through each of these. So decreasing the transmit gain settings, those transmit gain settings are those little sliders on most machines that should affect the brightness of the image, but it shouldn't affect frame rate at all. Decreasing the imaging depth is what we talked about earlier. If now you don't have to, if you have a less depth, you don't have to wait as long for the sound to come back, and so you can be finished drawing your individual sector line sooner and move on to the next one, and that will increase frame rate. Option C, which would be widening the image sector. Now, if you do that, you have more lines to draw because it's a wider sector, and so that will have the opposite effect. That will decrease the frame rate. And then E, lengthen the image focal range. That shouldn't have any effect on the frame rate. You're just moving the focal point in and out, but that shouldn't have an effect on typically your temporal resolution and your frame rate. All right, ready for the next question. An 8-year-old boy with aortic valve stenosis is found to have a peak systolic velocity across his aortic valve of 3.0 meters per second based on continuous wave Doppler assessment from an apical view. He subsequently undergoes cardiac catheterization, during which the peak-to-peak systolic gradient across the aortic valve is measured at 45 millimeters mercury. The discrepancy between the pressure difference across the aortic valve by Doppler echocardiography and the pressure measurements at catheterization is most likely related to which of the following? A, pressure recovery effects which are not adequately accounted for by the application of the simplified Bernoulli equation. B, use of continuous wave Doppler rather than pulse wave Doppler echocardiography. C, failure to align the Doppler beam parallel to the direction of blood flow through the aortic valve. D, the patient had a lower cardiac output at the time of catheterization. And E, the Doppler gain setting was too high. And then show the correct answer. Okay, so this step requires this question requires a couple of different steps. So the first is we need to say calculate what's the estimated gradient by Doppler echocardiography. So for that you need the simplified Bernoulli equation. So you take the 3.0 meters per second and square it, and that so the 3 squared is 9, and then multiplied by 4, that takes you to 36. So you have an echo gradient of 36 and a cath gradient of 45. So the echo is getting a lower measurement. So we have to find a situation or an explanation of why echo would give you a lower gradient. So if we look at option A, the pressure recovery effects, which are not accounted for, pressure recovery, again, typically that will lead to a lower measurement in the cath lab rather than a higher measurement. Because with Doppler echo, you're measuring the pressure at that vena contractor when the velocities are at their peak and their pressure is at their lowest, and then over a little more distance, a few more millimeters, the pressure comes back up as you have pressure recovery. And typically the catheter tips are distal after pressure recovery. So that would have the opposite effect. We clear about that? So Doppler echo, I'm going to spend just one more sentence on that since some people gave this answer. With Doppler, you're going to measure that higher gradient, if you will, the maximum gradient possible before those pressure recovery effects have kicked in, and those catheters are typically take into account pressure recovery because the catheter tip is downstream after pressure recovery has occurred. Okay, B, continuous wave Doppler rather than pulse wave Doppler. So using continuous wave Doppler would not tend to underestimate it, whereas if you would use pulse wave Doppler, you might underestimate it. Continuous wave will pick up that peak velocity because it's got range ambiguity. You don't know where you are, but it'll get all the velocities across the whole line. So you won't tend to underestimate using that technique. C, failure to align the Doppler beam parallel to the direction of blood flow through the aortic valve. So this goes back to the angle dependence of the Doppler principle that we talked about. If you're not aligned correctly with it, then you'll underestimate it by Doppler. And in fact, that's what's happening here. We're getting a lower Doppler gradient than we would expect compared to the cath gradient. So that's something that can lead to a lower measurement. D, the patient had a lower cardiac output at the time of the catheterization. If the patient had a lower cardiac output at the catheterization, you'd expect the echo gradient to be higher rather than lower, but in this case, the opposite is true in our example. The echo Doppler gradient was lower rather than higher. And then E, the Doppler gain setting was too high. The Doppler gain setting was too high, you'd expect the echo gradient to be unexpectedly high, but in this case, the echo gradient is unexpectedly low, and so that's going in the wrong direction for the change we saw. All right, question 3. You are performing an echocardiogram on an overweight 16-year-old male, and note that your 2D images appear dark and that it is difficult to resolve structures in the far field. This observation is most likely related to which ultrasound phenomena? A, high absorption, B, high reflection, C, piezoelectric effect, D, backscatter, E, range ambiguity. Good. Did you roll up the correct answer? So high absorption. This is where we're talking about the different ways ultrasound can interact with tissues, and one of them is for the energy of the sound waves to be attenuated or decrease as you go over distance. And that's what's happening here. The far field images are dark because of high absorption. High reflection would give you the opposite effect. Things would be bright. Piezoelectric effect, it's cool, but it doesn't apply to this situation. Backscatter doesn't apply, and range ambiguity applies to Doppler principles and not to this 2D imaging scenario. Next question, please. All right, this one's a little tougher. A 14-year-old girl has an echocardiogram 3 days after undergoing aortic valvuloplasty for chronic aortic regurgitation. Her fractional shortening is now 26% compared to 33% preoperatively. Graphs of her stress velocity and stress shortening data preoperatively and postoperatively are shown below with normal values between the dotted lines. Her depressed shortening fraction is most likely related to A, increased afterload related to an increase in systolic blood pressure, B, increased preload related to multiple boluses of saline to support blood pressure, C, decreased contractility caused by cardioplegia, D, decreased afterload from an increased dose of nitroprusside, an afterload reducer, E, decreased preload from a reduction in regurgitation. Good. All right. So E is the correct answer. All right. Let's go through this graph for a second here. So what we have on the vertical axis is that VCF parameter we talked about. It's the rate-corrected shortening fraction. And so that's the one where you divide by ejection time, and correct for heart rate. And the key thing about that is that one's preload independent. So this is preload independent, and that means that what's left is going to depend on either contractility or afterload, right? So we've got to deal with three things: contractility, preload, and afterload. Okay. Now on this graph, we have end systolic wall stress, which is a measure of afterload. And so we're taking that into account as well. And what you can see is from pre-op to post-op, we kind of stay the same in the same spot on the graph relative to the normal bars, okay? And so what that's telling us is that contractility is staying the same too. Because if we stay at the same points as we go along this, we're taking afterload into account. This is already taking preload into account, and what's left is contractility on this graph, okay? Put another way, you can see that as afterload increases, the expected contractility should decrease here as well. So this gives you some insight to say, okay, contractility is not the answer. So that allows us to take contractility off the chart. On the bottom graph, the other thing you can tell from both these graphs is what's happening to wall stress here, okay? Wall stress is going down. Both graphs show the same thing. At point 1, we're going at something like 75, and then post-op, we're going to a wall stress of 60. So afterload is doing what? Afterload is decreasing. And with a decrease in afterload, you would expect ejection fraction to increase. But the change we're seeing is not related, is in the opposite direction. So clearly, afterload can't account for the decrease in the ejection fraction, or sorry, the shortening fraction in this case. So it's not contractility. Afterload is changing, but it's changing in a direction that wouldn't account for the decrease in shortening fraction. The only thing left in this conversation, the third one, is preload, and that's why preload has to account for the changes here. So just going through the answers, increased afterload, that could account for a decrease in shortening fraction. However, in fact, when you look at these graphs, wall stress and therefore afterload decreased, it didn't increase. Increased preload related to multiple boluses, an increase in preload, you'd expect that to improve the shortening fraction. Okay, instead it decreased, so that can't be an explanation for the change that we're looking at. That would go in the wrong direction. Decreased contractility, a decrease in contractility would explain a decrease in shortening fraction, but this graph up here, the top one, the stress-velocity relationship, shows that contractility, is staying the same here. Again, relative to this bar here, you're staying at the same point. So contractility hasn't changed. Decreased afterload from an increased dose of nitroprusside, decreased afterload would be expected to increase the shortening fraction, so that's going in the wrong direction compared to the what in fact the direction we saw, which was a decrease in shortening fraction. And then E, the decrease in preload. One, that's what you might clinically expect to see in this situation, but I want to also show you can tell that from eliminating the other options as well. Next question, please. The Bernoulli equation used in echocardiography to calculate pressure difference between two chambers is based on what fundamental principle? A, conservation of mass, B, the second law of thermodynamics, C, conservation of energy, D, the Gorlin equation, E, the Fick principle. Good. Okay. So the Bernoulli equation is what we're going to use to calculate those differences in pressure, and we're talking about relating kinetic energy and potential energy, and the fact that you can't increase or decrease those, and that's where conservation of energy comes in. Answer A, conservation of mass, comes into account with the continuity equation, not the Bernoulli equation. Next, and the other ones are different principles not related to echocardiography. 6, a 15-year-old male seen in the outpatient clinic is found to have an abnormal electrocardiogram. He undergoes an echocardiogram which shows an end diastolic dimension of 5, an end systolic dimension of 4. Based on this data, what is the shortening fraction? A, cannot be calculated without knowing the end diastolic wall thickness. B, 20%, C, 25%, D, 30%, E, cannot be calculated without knowing the heart rate. Good. Okay, so the formula for fractional shortening or shortening fraction, same thing, end diastolic dimension minus end systolic dimension divided by end diastolic dimension. So 5 minus 4 is 1 over 5, that's 1/5 or 20%. So B is the correct answer. Let's go to the next one. 7, you are asked to evaluate an 11-year-old with progressive exercise intolerance. On physical examination, there is allowed S2, and his ECG shows left atrial enlargement. An echocardiogram is obtained with the mitral inflow and mitral annular tissue Doppler velocity shown below. These findings are consistent with A, normal diastolic function for age, B, abnormal relaxation, C, pseudonormalization, D, restrictive physiology, E, mitral stenosis. Good, restrictive physiology. So the things about this curve what we're seeing that are abnormal is you're seeing on the mitral flow a very elevated E wave compared to the A wave. So the E wave to A ratio is markedly abnormal, markedly high, and we're seeing the low E prime velocity. So that's why both the E prime and the E to A wave ratio are abnormal. That's why A doesn't apply. Abnormal relaxation, For that phase, we typically would see the E wave less than the A wave. You might still see a decreased E prime in that setting, but probably not this decreased. Pseudo-normalization is a reasonable thought. However, the E to A ratio is too high to account for that. And so that's why D, the restrictive physiology, which has the E to A ratio here, which is clearly greater than 2, is the better answer. And mitral stenosis, you wouldn't see these patterns. You'd see increased flow velocity in a different pattern and wouldn't expect to see the diminished tissue Doppler E prime. So you were asked whether there is a right to left shunt or intracardiac thrombus in a 16-year-old male who has just suffered an embolic stroke. A transthoracic echocardiogram and saline contrast bubble study do not reveal any abnormalities, but the image quality was poor. The NETS test to assess for a right to left shunt and thrombus in this patient is A, transesophageal echocardiogram, B, gallium-67 nuclear scintigraphy, C, really? Okay, C, cardiac catheterization with angiography, D, cardiac magnetic resonance imaging, E, exercise stress echocardiogram. We could end there. This is a strong indication for a TEE and common in the adult world as well as in the adolescents to be able to rule out a right to left shunt or rule it in as well. All right, thank you.